Fine. So we start. Correct? Okay. So we are talking today about lesions of visual pathway. Right? So when you talk about lesions of visual pathway, a quick revision, I chose this topic because so many times after my class, the students come to me and tell me, ma'am, aaj samajh aaya. So I feel it is challenging in the beginning to really understand. So let's discuss this only. We first talk about, let's talk about our visual pathway first, correct? So just to revise your visual pathway. So this is very beautifully depicted here. I think everybody can see this now. This is your left retina. This is your right retina. Simple. Left ka left patti, right ka right. Okay. So when we are talking about felix. Now we all know that, be very clear, that projection of retina is opposite. If you will look at your left retina here, can you see the nasal part is actually colored purple or blue, whatever you want to call it, and the temporal part of the right eye, right? So it's a cross projection, which means this part of the retina is responsible for this field, and my nasal part of right eye is responsible for this field. It's always crossed, right? So this is what you are seeing here as a color depiction. So this is your left retina, right retina. Make it very simple. The nasal fibers are decussating, and that is what is called optic chiasma, right? And the temporals are not. So first of all, it is forming the optic nerve, then the optic chiasma, right? What next? One eye temporal and other eye nasal fibers from the other side, and same side temporal. So this is your optic tract. After the tract, you first listen and then we will write together. We'll make it more simple. So after the tract, this is lateral geniculate body. And from here, what we are seeing is optic radiations. So the outer one is which are the fibers passing through the temporal lobe, and then the parietal, and finally the visual cortex. Okay. So this should be very clear to us. What is the visual pathway? What is our visual pathway? Okay. So let's go back. And let's write together. Okay. So सबसे पहले we are all going to make the visual pathway. Okay. So all of you now draw. I generally simplify it so that it is easier for us. So in our simple terms, if this is our left retina, right? And this is our, wait a minute. Let's make it a little better. So this is your left and this is your right retina, right? Now, on your I hope you're drawing with me and you're writing along with me. We will divide it into nasal, temporal, right? Now, we all know nasal fibers, I said, will decussate and form the chiasma. Temporal will not decussate. You can use a different color if you want for temporal, otherwise it's okay. We can see it very clearly, right? So the nasal fibers are decussating, temporal is not decussating. This becomes your optic nerve. This is your optic chiasma, optic tract, right? Then lateral geniculate body. So this is your lateral geniculate body. From there, of course, the optic radiations. I'm making it in a simplified form, so I'm just making this like this. So the optic radiations, you have seen how some fibers are going temporally and then through the temporal lobe and some through the parietal lobe. We know this very well. For ourselves, we are just simplifying. And of course, then comes our visual cortex, right? Yeah, an oversimplified version of what we are studying. Okay, now when you talk about lesions, we take one by one. What are the lesions of the visual path? This time we will first note it down in our style and then we will see this other slide. So all of you, suppose I take the left-sided lesions, right? So left side, if I say left-sided optic nerve is gone, this is lesion number 1. So if left-sided whole optic nerve is gone, common sense, this lesion number 1 is going to cause whole optic nerve gone means ipsilateral blindness, right? So it is ipsilateral blindness. Come to our next situation. The next situation can be when only the nasal fibers exactly at the decussation there is a lesion. Out here, this is number 2 lesion. So this is a concept which is very, very important for you all to understand, that as I told you, the projection of retina is opposite. So to more simplify in your mind, you can just understand this, that field defect is opposite of anatomy. If the nasal fibers are gone, it has to be a temporal field defect. If temporal fibers go, it is a nasal field defect, and superior fibers, inferior field defect, inferior fibers, it is superior field defect. If we are clear with this, we will understand the whole thing. ठीक है? So anatomy के just opposite होंगे हमारे field defects, and I explained you why, right? So now when there is a lesion of both the nasal fibers, what should be the field effect I am going to make here is, this is the left-sided field, left eye ka field and right eye. This time I am talking about field. This is not anatomy, okay? So bitemporal. So temporal yahan ka bhi and temporal here also. It should be exactly equal. So bitemporal hemianopia. Why do you say hemianopia? Half of the field is there, half is not. So we say bitemporal hemianopia. Okay. This is your number 2 lesion, which is chiasmal lesion. We will talk little more in detail later. First we talk about the basics. Next we come to tract. Now when I talk about tract, it is so clearly given in the diagram कि one eye का temporal and one eye. I told you we will be trying the left-sided lesion. So if I tell you left-sided optic tract lesion is the number 3 lesion. So all of you, what you can see, left side temporal fibers are gone, but right eye ka nasal fibers are gone. Okay? So if when we come to the field effect, number 3 lesion, what is it causing? Left side temporal is gone means it is a nasal field effect of the left side, left eye, and right nasal is gone. Can you see that? Right nasal. So temporal field effect. Okay? Now, what do you see? Both the shaded part. Okay, some of you even asked me this. Which one was normal? And the shaded part is the one which is gone. So this shaded part which is gone, can you see it is all on the right side? So we will say, and it is on the same side, so we call it homonymous hemianopia. So अब इसको क्या बुलाएंगे? Right homonymous hemianopia. ठीक है? So right homonymous hemianopia. So keep this in mind. Left-sided lesions always will cause right-sided field effect. Okay, so we can think like this if we are talking about homonymous hemianopia. Okay, and then we talk about what about radiation lesion and what about cortex. Look at this diagram. I don't see any further decussation or disturbance. It is the same one eye temporal, other eye nasal. These fibers are continuing in LGB, optic radiation, visual cortex. And this is the reason, if I talk about the basic, the main radiation lesions, that is number 4 lesion, right? It will again be Same, so easy to learn. So whether I'm talking about tract, I'm talking about radiation, I'm talking about visual cortex. So what is the type of lesion? It is one eye temporal, one eye nasal, and hence this is what is your right-sided homonymous hemianopia. I want all of you to learn along with me. We will talk a little more. Let's just first start with the basics. Okay, keep learning along with me. And what about number 5 lesion? Kisko bola humne? We are talking about the visual cortex. So any lesion in the visual cortex again is going to lead to the same right-sided, because I have taken the example of all left-sided lesion. I will say right-sided homonymous hemianopia. Okay, so all of you, now I ask you a question, all of you there. So, am I trying to say there is no difference? What about tract lesion, in radiation lesions and visual cortex? Is it a full description, that is right homonymous hemianopia in all this case? No, we are missing one important term, and that is it congruous or incongruous? Okay, so actually if you look at, it may not be exactly both sides the same area. So when your field effect on your left eye field and the right eye field is almost exactly similar, that means symmetrical in continuity, we will call it congruous. Okay? And not similar, we call it incongruous. So though we have made this simply to learn like this, but we should know this, that when I talk about a tract lesions are incongruous homonymous hemianopia. Okay, so I may just, if I want to make a incongruous, I may not put everything shaded here. I just make a little bit shaded here and not. That means it is not symmetrical, though it is a homonymous hemianopia. Okay, now next, this is your incongruous. Incongruous ka matlab, I always tell you, is also not symmetrical is one thing, and second is, I said what do you mean by when will it be symmetrical and when it will be not be symmetrical? When the two corresponding retinal points, say whatever fibers are coming, they are aligned close, you always get a symmetrical field effect. Okay, so learn with me together. Optic tract is incongruous, and yes, this question comes to me so many times. If I talk about optic radiation, number 4 was, look here, it is optic radiation. Okay? If I talk about optic radiation, it can be both incongruous and congruous. Why do I say so? Because anterior part of the radiation creates an incongruous effect. As we move posteriorly, it creates a congruous visual field defects. Okay, so we mark incongruous or congruous. It will depend anterior posterior. Now coming to cortical lesions, always congruous homonymous hemianopia. Okay, why it is always congruous homonymous hemianopia? Okay, so Anu, you can ask me this question a little later, because I'll talk about that. I will use this term later in my description. Okay. Otherwise, just clarifying you, anything in a very narrow field is a keyhole or a tubular vision, but the term keyhole is mainly used for visual cortex, macula sparing homonymous hemianopia. I'll just come to this. So one by one, if you come, you are more clear. Okay. So why congruous? All of you, why it is? Because in a very small area of the cortical area, all the fibers are aligned closely. Therefore, any lesion there is causing you a continuous or symmetrical defect. In both eyes, it is symmetrical and continuous. Okay. So this is what has come. So what did you learn? Let's quickly revise. What did we learn? Left eye, right eye. Divide into nasal, temporal. Nasal fibers decussate. Temporal does not. So optic nerve, chiasma, optic tract, lateral geniculate body, optic radiation, visual cortex. ये हो गया आपका visual pathway. One by one, very quickly. Left-sided lesions I'm taking as an example. Left optic nerve gone, left-sided blindness. Second, when there is a lesion at the decussation, what do you get? Bitemporal hemianopias. because both nasal fibers are gone. What do you get in 3, 4 and 5? Learn with me. Opposite side. So it's a left-sided lesion. So opposite side, it is homonymous hemianopia. Right? So opposite side, when you say homonymous hemianopia, please remember, purely congruous lesions are the visual cortex or the posterior radiation lesions. Otherwise, they are incongruous lesions. That is asymmetry. Done? Okay. Now we talk about, once you know this, look at your field effects. Once more what you have written. I hope you all are writing. That's very important. Huh? So since childhood we keep listening that if you write you learn better. So always your notes are most precious thing you have in your hand. So if you look here, all of you, 3 is on the same side, 4 is on the same side, 5 is on the same side. So it's a homonymous hemianopia. But what about number 2? 1 on the left, 1 on the right. So this is also called, as you all know, heteronymous hemianopia, right? So chiasmal lesions are heteronymous hemianopia, right? So very important, you all can note this in a box. I generally ask you all to make boxes for all the important concepts that we mentioned. So here, put it in the box that the only lesions which are heteronymous are chiasmal lesions. The only lesions which are heteronymous, kaun se ho gaye? Only, because this is also frequently asked. So only lesions that are heteronymous. Can you see this? Do you agree? In this, it is chiasmal lesions. Note it down. So you will keep this in mind. Right. Now coming to little more about each of them, making it a little more interesting for you all. So we will see a few slides more. When I talk about, chalo, we start with chiasma, correct? So once you have understood about chiasma, that chiasma is mainly if exactly central lesion at the decussation of the nasal fibers, we are getting bitemporal hemianopia. Done? Okay. What are the variations? What are the other possibilities? Some of you must have learnt it. Yes, it is mid-chiasmal sort of. That is correct. So, but it could be, what is anterior junction, what is central lesion, and what is posterior junction. Very simple. Let's understand. So it all depends. If the anterior part of the chiasma, anterior junction syndrome is what? Let's understand that now. Let us see these slides first, and then we go further. Ye wala ho gaya, right? So this again has been already described, and I am going to describe it further little later about optic radiations and visual cortex. Let us learn one by one and learn together. Okay. So this is a field effect. Can you all tell me what type of field effect here you are looking at? Would you like to answer this? This slide, what type of field effect that we are just studying also? This is your, okay. Come on, I'm going to wait. I need this answer here. What is this field effect you are looking at? So, what is the field effect? Which hemianopia? Sort of which hemianopia? कौन से side का नहीं दिख रहा? So, this is what is bitemporal. Yes, Indrani. So, this is what is bitemporal hemianopia. Can you see that? Both eye nasal field is fine and the temporal field is gone. So, this is what you see in a central chiasmal lesion. Right. Now we talk about what is anterior junction syndrome. Now here what is happening, as you can see so nicely described here, that the lesion, this lesion is at the junction of the nerve in the chiasma. So that, now what is happening? What is this causing? This is actually affecting the optic nerve of one side, in this case on the left eye, and for the right eye, It is affecting the inferonasal fibers. Look at this one. So what happens is, of the other side inferonasal fibers, before crossing, they detour, घूमने चले जाते हैं थोड़ा सा. Okay, so they detour towards the optic nerve, and this is what you call anterior Wilbran's knee. Okay, so can we remember this? Inferonasal fibers are first going to the opposite side, saying hello to the opposite optic nerve, and then crossing the chiasma. Okay, so this Wilbran's knee of Wilbrand or Wilbran's knee will lead to what? If there is any pressure here, so if these fibers are affected, we just saw the lesion was somewhere here. So what was happening? This was affected and the nerve was affected. Look at this one. So if this is happening, any inferonasal, I told you field is opposite to anatomy, so it will lead to inferonasal fibers gaye to superotemporal. So inferonasal fibers will lead to superotemporal field defect. You understand first and then we write together. Okay, so inferonasal fiber of the other side, which is called Wilbran's knee, and the optic nerve fibers of the same side. This is anterior junction syndrome. This is the anterior part of the chiasma is being affected. Okay? So anterior junction syndrome or anterior part of the chiasma is most commonly affected in what? So do you all know? I think everybody knows this, that chiasma will be affected in pituitary adenomas or craniopharyngiomas. If you remember your anatomy, right? Look at this. If you remember your anatomy, right? So this is your optic chiasma. This is the pituitary gland. Now, depending on the relative position of chiasma and pituitary gland, we can have different presentations. So what happens is this. Majority of the times, 80% of the time, it is central. Then I will get a bitemporal hemianopia due to pituitary adenoma. This circle, this brown circle is your pituitary. But this is the pituitary gland and this is the relation. So any tumor from the pituitary gland in a central position, you get a bitemporal hemianopia. This is why we call it central lesion. We can write a bitemporal hemianopia. Now talking about let me take first this postfix. What is prefix, postfix? Well, can you see that? It's very clear. Where chiasma is coming before the pituitary is pre. Pre, and then after the pituitary or posterior, this is your post. So postfix is another 10% of people, and any adenoma in this case is going to lead to, can you see that? Because it is postfix, it is mainly causing anterior part of the chiasma is affected. So anterior junction syndrome is going to happen in postfixed variety, and vice versa. There is another when the posterior part of chiasma is affected here, as you see, because as you can see here, so this will cause posterior junction syndrome. Okay? If you have understood with these slides, we will like to note it down for ourselves, right? So let's do that now. Okay, so let's do this as for ourselves. Once we know these basics, we come to chiasma. Give the heading chiasma and note down all of you. So when you talk about chiasma, we divide it very simple into 3 parts. We have understood this. Central chiasma lesion or central lesion, which is occurring in 80% of the people, will lead to bitemporal hemianopias. Right? We saw that. Now, anterior junction syndrome. Do you know it is also called, you know the other name? Junctional scotoma of Trachar. Trachar is the name of a scientist. So we can also call it junctional scotoma of Trachar. Saurabh, what, why? फिर से पूछो. Junctional scotoma of Trachar. Let's note it down for ourselves. ठीक है? So this junctional scotoma of trachear or anterior junction syndrome is optic nerve of one side. So in your example, you saw optic nerve of one side. Suppose, for example, the slide that you saw, it was left-sided optic nerve with right-sided inferonasal fibers. What are these inferonasal fibers? We call them Willebrand's knee. Please note down. So this is nothing. It is detouring to the opposite side and then going to the chiasma. It is a normal anatomy. So any lesion here, why do you call it junctional? At the junction of nerve and chiasma. Almost at the most anterior part of the chiasma. In that case, what I will get is central scotoma on that side. This is a very, very frequently asked question. Okay. Of that, which side in this example? In this example, this is your left side. Left eye central scotoma, and right side we will get superotemporal quadrantopias. Superotemporal quadrantopias. Okay? Now we come to posterior junction. These are mainly, I told you, in prefixed chiasma, you can get a posterior. So when the posterior part of chiasma, you have to know, is mainly macular fibers. So posterior junction syndrome will involve a heteronymous macular lesion. A macular lesion but not homonymous. So this side macular here and this side here. एक left side, एक right side. Depending on, so this is your posterior junction syndrome where you are getting a macular heteronymous hemianopia. Okay, so this is actually macular heteronymous. I told you chiasmal lesions are all heteronymous. Remember that. Okay, so this will lead to macular heteronymous hemianopia. Got it, guys? So this is about chiasma. Okay, Saurabh, left eye is not full because not all fibers are damaged. If all fibers are damaged, it will become a full blindness. So it depends. If few fibers are damaged, then it will only cause, आपने पढ़ा है ना, optic nerve lesion, optic में you get central scotomas, then we only get central scotoma. When all the fibers are gone, then you can get an ipsilateral blindness. ठीक है? So this is your posterior junction and this is about your chiasma. Is there anything else? Yes, one more thing we will learn about chiasma before I move to optic tract. So what is that? Another additional thing that we will look out here is, look at this. What is this? One eye up, one eye down, one eye up, one eye down. So this is also, what is this? Any involuntary eye movement is nystagmus. Correct? So this is your seesaw nystagmus. We call it seesaw. So it is generally a feature of bitemporal hemianopias. Okay? So it's a feature of bitemporal hemianopias. That means, I'm talking about chiasmal lesions. I'm talking about chiasmal lesions. Okay. Done? Okay, once we know this, note down this also please. So these are all the features and we should know this much about our chiasma and our chiasmal lesions. Okay, one more important point that you should know, pituitary gland being below the chiasma naturally is first going to cause a superotemporal defect and slowly it will cause hemianopia. Okay, so you can note this point as one more point here, that if I talk about if there is a pituitary, we all know chiasma is affected in, can we note this in the box? Main causes of chiasmal lesions generally are, so this is asked. So chiasma can be affected in, let's note down, affected in pituitary adenomas, all of you, ठीक है? Learning now? Please learn along. Right? What next? Pituitary adenomas. Second is craniopharyngiomas. And third is aneurysm circle of Willis. If anybody has forgotten, revise your anatomy. Circle of Willis. Aneurysm circle of Willis. Just revise this. So these are the main problems because of which you can get chiasma lesion. So what I'm trying to tell you here that you should additionally remember about, if I talk about pituitary adenoma, because it's mainly the inferior fibers involved first. So the first defect is superior quadrant. It can be superior defect, isn't it? So superior bitemporal के बदले पहले superiotemporal, then it is involving the other part of things. है ना? Temporal field is gone now. So because this is below, so it will first involve the inferonasal. Then we talk about craniopharyngiomas. Craniopharyngiomas will start first as inferior quadrantopia or inferotemporal, and later it will extend like this. Okay, so later this extends like this, craniopharyngioma, and this will extend like this. So pituitary adenomas pehle superior defect show karte hain, then they become hemianopias here, correct? And craniopharyngiomas are first inferior defects and then they move superior. Okay? And can you please repeat your question? Which inferior fibers you were talking about? Are you which inferior fibers you are saying? So this was about your, just write your question, I'll answer. So this was about your chiasma. Now we talk about is optic tract. Come back to this. When I'm talking about optic tract, all of you, when I'm talking about optic tract, I'm coming to this diagram again, go back there. Let's think something. So it will cause homonymous hemianopia. This is done already, right? Okay. If it is so, what is the pupillary reaction? What pupillary reaction you get here is a very, very important question. So another important point about optic tract lesion is Wernicke's hemianopic pupil. Okay, so let's take another page. It's easier, cleaner. So we will again take this to understand what is Wernicke's hemianopic pupil. So give the heading optic tract and let's learn this. This is the nasal, this is the temporal, right? So I have just made this again to explain you. Chiasma, optic tract. Then comes your lateral geniculate body. And further you know what it is, right? Okay, so now we are understanding what is Wernicke's hemianopic pupil. First of all, hemianopic you have understood is half and half. Half is present, half is not, right? And we have been taking all the lesions of the left side. So if I tell you it's a left-sided lesion, left optic tract is gone here. So my first feature of optic tract lesion, give the heading optic tract. What are the points we will remember? An optic tract lesion, first of all you can note down is, so in this case if I take the left side, it is right-sided homonymous hemianopia. Correct? Okay. And then I'm talking about Wernicke's. What is Wernicke? It's a name. Okay, Wernicke's is a name. Hemianopic pupil. Wernicke's hemianopic pupil. So what is hemianopic? Now I want all the attention. Okay, and I'll just show you. First, let's complete this. So what is Wernicke's hemianopic pupil? So Wernicke's hemianopic cannot be tested so easily. First prerequisite, patient has to be in a dark room. I want all the attention this time. Nobody should be writing anything. Just listen first. So what I'm saying is that the patient is sitting in the dark room. Now I am supposed to use a pencil torch, not the big torch, because I want a narrow beam of light. Okay. Now in this case, this patient, I've already drawn the tract in front of here, the diagram in front of you. What happens is, The patient is sitting in front of me. It's dark. I'm using a pencil torch. Now I'm throwing the light in such a way that it falls on both his eyes. Okay. But it is not whole retina. It is almost falling as on the hemi-retina, half part of the retina, because it's a very narrow beam. And that is why it needs a lot of expertise to manifest a hemianopic pupil. It's not easy. So when you are showing like this, what you see? Okay, reaction is normal. Okay. Now you change the direction of the light. Now look at both the pupils. No reaction at all. So from one side, normal reaction. When I am showing it from the other direction, there is no reaction. Hemianopic. Adhi pupil is reacting, half is not reacting. Hemianopic. So this is a feature of optic tract lesion. Now I will explain you how. Look in the diagram. If I say this left-sided, I made this arrow that this is gone. Do you realize it means left eye ka temporal chala gaya? Ye, this is gone. And right eye nasal is gone. So these parts of the retina are not working in this patient because of the lesion here. Am I clear to all of you? So if I am showing the torchlight, my pencil torch from this direction. If I am showing my pencil torch from this direction, my light is only falling on these parts of the retina. I am putting a tick here because here I will see a normal reaction. Okay? And when I change the direction of my torch, pencil torch ka direction badal diya. This time the light is falling on these parts of the retina which are not working. So this is the reason I am getting normal reaction from one side and no reaction from one side. So this is a hemianopic pupil. Vernix किसी का नाम है. So ultimately Vernix hemianopic pupil is a feature of, what is your answer? Optic tract lesion. Okay? Now I have a question for you all. Tell me, if this is the reason, the same pattern is of temporal. Why it is happening? Do you realize? Because of one eye temporal, one eye nasal. But the same pattern goes in the radiation, the cortex. Why are we learning only for this optic tract? Can you see here, all of you? Optic Vernix hemianopic pupil. Why I am not telling you that it can be seen in radiation lesion or cortical lesion? Why it is only a tract lesion? Now I need an answer and I'll wait for this. Come on, fast, fast, fast. Answer me quickly so that whatever I have thought of covering, I should be able to, we should not be short of time. So quickly tell me. Yes, Divya Aditya. Yes, it's a beautiful name. Yes, it will be all repeated. Don't worry about that. Answer my question. Yes, Indramni. So finally, I'll have to ask you to stop answering first. Huh? No, I'm just joking. So, do you all realize something? Do you remember your normal pupillary reaction? Huh? What is your normal pupillary reaction? The light from this. Okay, इसी में बता देते हैं ज़्यादा आसान. So light from the retina, when you show light, goes into your optic nerve, chiasma, optic tract. Does it go down? No. From the tract, everything deviates to pretectal. Isn't it? Let's look at the light reaction. You should be clear about this. So, look here. This is your pupillary light reflex. So we know when you're showing light here, suppose you have shown in the left eye, how it is first afferent pathway through the nerve, chiasma, tract, it is going to Pretectal. From the tract itself, it deviates and goes to pretectal, then Edinger-Westphal. This is your afferent pathway. And efferent, of course, we know is through the third nerve and ciliary ganglion. Right? So what is important that to remember here is that because the light reflex pathway is not going down from tract, it is deviating into the pretectal nucleus and Edinger-Westphal. Therefore, hemianopic pupil is only a feature of tract lesion. Correct? Okay, if you know this, am I trying to tell you all? In that case, do we also... Okay, before I ask you the next question, what are you looking at here? Saurabh, I want you to answer this. What is this? What are you looking here? Which type of field effect is this one? Come on, answer. Saurabh, कौन सा field effect है ये? So what you just saw was, okay, I will not answer, you answer this. So do you realize because it goes to pretectal nucleus? My next question, do we mean that in the lesions of optic radiation and visual cortex, pupillary reactions are normal? Are we saying this, that pupillary reactions are normal? Yes. Okay, so I want you all to make another box here and note down nicely so that you never forget. In radiation lesion and in cortical blindness, pupillary reactions are normal. Okay, pupillary reactions are normal. Right? From pretectal, every pretectal is innervating both Edinger-Westphal nucleus, right? So we'll discuss more in detail when we discuss pupils and all. We are talking about lesions, so we come back to optic tract lesion. The 2 points that now you remember is homonymous hemianopia, vernix hemianopic pupil, number 2. Then note down an important point, that this in the box. Another important thing is, when there is a tract lesion, we also learn about a pattern of atrophy which is called bow tie atrophy. So when you are looking at the disc, what do you see? Now think yourself, in this case, so these are 3 terms you will remember for this lesion. One was this, second was vernix hemianopic. Now the third term I am coming to. So listen, you know that in a left-sided lesion, left eye ka temporal is gone. And what about right eye? Nasal is gone. Let's note it down what we just said. So if I talk about optic tract lesion of left side, I said, iska matlab left eye ka temporal is gone. Right eye, nasal is gone. So do you know what is happening? Same side, that is left-sided tract mein, left eye mein, temporal fibers are only gone. Do you remember in glaucoma chapter, I generally discuss, okay, maybe many of you have not heard me, you are hearing me for the first time. So a very important diagram about the pattern of the nerve fibers that aggregate on the optic disc. So if this is your optic disc, if suppose this is the whole retina I just drew for you, okay? And this is your optic disc, ye ho gaya macula, this is temporal part, this is the nasal part. This is whole the macular area. Okay? Right? Now what you have to understand, pattern of the nerve fibers, how? We all know, na? From the whole retina, nerve fibers aggregating at the disc and forming the optic nerve. So what this diagram I am teaching you is, how is this aggregation taking place at the disc? So the fibers from the macula, they travel straight to the disc. This is your papillomacular bundle. Fibers from the nasal half are traveling like this straight. These are called superior radiating fibers. These are inferior radiating fibers. Okay? And what about the temporal side se jo fibers aate hain? They curve around the macula and enter the disc ऊपर से and नीचे, from superior and inferior. So common sense. Left side only temporal fibers are gone. So what I am going to get? The pallor that I see on the optic disc, the neuroretinal rim that will be affected will be superior and inferior. Correct? What happens on the other side is nasal and macular, nasal, macular as well. So what happens now that in this case, horizontally, so all this is coming like this, okay? Don't get confused. Yes, like this and like this. So what you see a typical atrophy is, this is the cup, the neuroretinal rim is seen pale here, is seen pale here. Okay, and this is what is bow tie atrophy, typically seen in the optic tract lesion. Okay, so this is the reason you saw. So this is the third term I want you all to remember about optic tract lesion. Okay, once we know these points on tract, we come to optic radiations. थोड़ा सा quickly move करेंगे. We come to optic radiations. Right? I think it's clear now. This one, why you are getting this bow tie? Radiation lesions. I told you, optic radiation. Now, how will you learn first? I have already shown you the slide that optic radiations. Some fibers are passing through the temporal lobe and some they are passing through parietal lobe. Is it clear? Okay. So when I say temporal lobe, okay, so temporal lobe we all know it is the inferior fibers which will loop around the temporal horn. What do we call that? Mayer's loop. And from parietal, it is the superior fibers. We will learn this very easily. And this loop also has a name. If you want to know, this is Baum's loop. It is AUM. Okay, Baum's loop. So common sense. Another, because these were not all the fibers. Posteriorly, the whole thing, when it goes, the lesion becomes more posterior in the radiation. Then you get homonymous hemianopia. You already have learned with me. We can get incongruous or congruous homonymous. The more we go posterior, we get a congruous homonymous hemianopia. But this time, few fibers passing through temporal lobe or passing through parietal. So now, any temporal lobe lesion, common sense, inferior fibers are gone. So give the heading temporal lobe lesion में क्या क्या मिला? So temporal lobe lesion, inferior fibers are gone. We get a superior quadrantopia. This is what is called pie in sky. This is your superior quadrantopia and this is what is pie in sky. Okay? And vice versa, if it's a parietal lobe lesion, क्योंकि superior fibers are going, we will get inferior quadrantopia. It can be of whichever side. And this is what is called pie in floor. Pie in floor. Okay. So one is pie in sky and pie in floor. That is inferior quadrantopia. Yes, Anna. PMB is papillomacular bundle. Papilla is the place where your optic disc is situated. Macula se papilla tak. Papillomacular bundle. Okay, very simple. Now I want you all to listen again. Pay attention. What can be the... So once we know about pie in sky, pie in floor is a very commonly asked question. You should be very, very clear. What else we have to learn about temporal lobe lesion apart from this? Please do not forget about that any temporal lobe lesion can lead to hallucinations. Okay. Generally, these are formed hallucinations. That means actual, maybe you see the actual picture of a person or something. Okay. And there can also be gustatory or olfactory hallucinations. So these are some additional features I would like to remember for temporal lobe lesion. There may be more. Neuro people will teach you. This much from my side, because hallucinations we talk about, hallucinations is related to us, so I'm mentioning this. Right? Now we talk about is parietal lobe. Is there any additional thing? Not in pine's floor. Pine floor के अलावा posterior parietal lobe, posteriorly when there is a lesion in the optic radiation, that means posterior part में optic radiation lesions, or posterior also optic radiations is already, this we already know is homonymous hemianopia. Along with that, posterior part of the parietal lobe is involved. Posterior part of parietal lobe can affect your optokinetic nystagmus. So because of this, you can get defective optokinetic. So what is the next point for parietal lobe lesion? One was pine floor, but if the lesion is more I'm repeating, just got little, don't get confused. So what I'm saying, pine floor, but as we move more posteriorly the lesion, it can lead to manifest as defective optokinetic nystagmus. ये क्या चीज है? It's a physiological nystagmus in all of us. Optokinetic nystagmus is defective in, this is a question already asked in your exam, and the answer is parietal lobe lesion. So it happens in parietal lobe lesions. I'll just explain you what is optokinetic nystagmus. So what is optokinetic nystagmus? If we look here, let us have a look at it. It will be more clear to you all. So whenever you are looking at a moving object in front of you, when your eye is actually following that object, we call it pursuit movement, and reflex is saccadic. Now look at this one. See. So this is these movements, pursuit and saccadic. This is what is your optokinetic nystagmus. So what you have to understand, this is your physiological nystagmus which is present in all of us. So when there is more posterior lesion in the parietal lobe, it can lead to defective, where actually what happens is that this pursuit movement is affected. Okay, so once again for you all, following movement is pursuit and refixing. For example, I give you a very common example. You are sitting in a moving train, another train crosses you. Are you listening? You are sitting in a moving train, another train crosses you. So your eye is moving at every passenger. So this is your pursuit. You go to the next. This is saccadic. Pursuit, saccadic. Pursuit, saccadic. Okay. So this is your normal physiological optokinetic nystagmus. And this gets affected in case of parietal lobe lesion, right? So this was about optic radiation lesions and the points to remember. We next come to visual cortex. The last one is your visual cortex. Very simple. You should just understand this way that visual, we know it is homonymous hemianopia. It is congruous. We know that. What else we have to know is, because majority of the times it is the vascular cause, let us learn like this, that visual cortex supplied by posterior cerebral artery. Okay, majority is supplied by posterior cerebral artery. All of the peripheral field is possible and supplied by this, the area responsible for your peripheral field is mainly supplied by posterior cerebral artery. This is what I mean to say. And second is middle cerebral artery. Now middle cerebral artery, M for M, supplies the macular area. M for M, yaad rahega? Macular area, which one is that? Almost at the tip of the calcarine cortex or visual cortex. That tip is macular area. So mainly supplied by middle cerebral artery. Okay. Now posterior, therefore any blockage of posterior cerebral artery, of course I am going to get a homonymous hemianopia. But macula is spared. So this is what you learn. If this round area macula I am leaving, the rest shaded part is gone. This is your macula sparing homonymous hemianopia. Okay? So this is what is macula sparing homonymous hemianopia. Vascular lesions will not cause macular. It is only any trauma which actually hits the macular area. Then after trauma, if the macular area is affected, then you can get a macular homonymous hemianopia. When macular area is damaged, trauma at the macular area of the visual cortex I am talking about, then I can get a macular homonymous. Why I am not getting with blockage of middle cerebral? Because some it's a dual supply. Some of the branches of posterior cerebral are also supplying here. So any vascular cause say kabhi bhi total macular lesion never happens. Okay, generally majority of the times. Now we come back to macular sparing homonymous. Can you see this? See this macular sparing homonymous. If you see here, this at some places itself, this is called keyhole vision, but at many sources it is described little different. So we see both the cases, because can you see here? So this thing is your keyhole vision, right? Sometimes even this is correct, so both are correct. Okay, we generally face this so frequently. Both side PCA is gone, though it is rare, it can happen. So now we learned that मान लो ऐसा हो जाए that even the what happened? So even your other side PCA is gone, then other side also I get a macular homonymous hemianopia, isn't it? So the other side also I get macular homonymous hemianopia. Macular sparing, I mean, sorry. So on the other side also macular sparing. Now what you see? What will be the vision of this patient? One of you were asking me now about keyhole. So either that is also at some places mentioned as keyhole, but many times this is said keyhole is nothing but a narrow visual field, tunnel vision that we talk about. There are many causes in the retina. Okay. Or it could be when both sided PCA is gone. अब मरीज को बस यहाँ दिख रहा है only this macular area, है ना? This is only left. Rest all shaded part is gone. So this is keyhole vision, or you can call it tunnel vision. So this is another perspective of a keyhole vision. I'll again repeat, at some places a simple macular homonymous hemianopia is also termed keyhole. But many sources have said that if both sided PCA is gone, now everything is gone and only the macular area is remaining, this is your keyhole vision or tunnel vision. So one of you were asking me what are the causes of tunnel vision. I would like to answer because I promised to. So apart from this macular sparing, that means visual cortex lesions, what else you should know about tunnel vision is late stage of retinitis pigmentosa. Okay, so we can talk about macular sparing PCA, that is bilateral occipital lobe lesion. This is one we have just discussed. Right? Then we are talking about late stage. I cannot take retina here, but yes, you can note down the list. Late stage of retinitis pigmentosa. Then sometimes when you have a cilioretinal artery, but there is a central retinal artery occlusion, we will learn all in detail. Okay, this can be another cause of your keyhole vision or tunnel vision, tubular vision, all terms are same. And quinine toxicity can be another one. Another drug which can cause constriction of the visual field, may not always be tunnel, but yes, is vigabatrin. So we can know this as well. Okay, so these are some of the causes. One of you had asked me, so I'm trying to tell you this, right? What are the other points to remember for the cortical lesion? Well, very quickly, apart from knowing this, macular sparing homonymous hemianopia, then we talked about macular homonymous after trauma, correct? Keyhole vision is what we learned. Now, few more points. Again, we get hallucinations as one point. But this time it can be like you are seeing, the patient is seeing some lines, some dots, some stars. So it is called unformed hallucinations, visual hallucinations. This can be another important feature of visual cortex lesion. Okay, what else? You should know what is Anton syndrome. Just one line, note down. This is cortical blindness तो होती है. Cortical blindness means any blindness due to visual cortical lesion. So cortical blindness with denial of blindness. This is called, he is blind, he is cortically blind, but there is a denial. So this cortical blindness with denial is called Anton syndrome. And what is redox phenomenon? So in this type, again, patient is only able to appreciate a moving object. Okay, that is called redox phenomenon. So a type of lesion where you can note down that patient can see only a moving object. Can see only moving objects. Okay. You see, you all people in Rangni, you are so busy chatting, bache. Everybody is busy chatting. Are you all listening to me or not? Okay, so this is the main points regarding lesions of the visual pathway, and these are the points we have to keep in mind. Okay, so what next we will talk about is time for you all to answer a few questions, right? Chalo, all of you, if you all have talked to each other, now answer a few questions. Answer this question. So if you have learned nicely, you can answer all these questions. So all of you, what is the answer to this question? Mark the correct options. You have to pick up the correct options. Homonymous hemianopia is seen in lesion of. So what should you answer? Okay, Indrani. Bless you. Chalo, batao fir. Fatafat batao. All of you tell. What are the options I will mark? What is the answer of this question, all of you? A, okay, C. Oh, sorry. This is the question. Sorry. So, homonymous hemianopia is seen in lesion of. Okay, A is correct. Then C is correct. And then E is correct. Right? So, this should be your answer. Thank you, Devyani. Now, answer the next question. Then you all leave. ऐसे नहीं. So, what is mark the correct statement? Wernicke's hemianopic pupillary response. पढ़ लिया ना? Is seen in lesions of. Quickly, Wernicke's hemianopic pupil is a feature of. What is the answer? शीतल, किसका आंसर C बता दिया आपने? Okay, AC is already done. We are coming to next question. Look at the next question. So, Wernicke's hemianopic pupillary response is seen in lesions of. Okay, very good. Yes. Question number 2. We all know it is tract lesion. Optic tract lesion. Okay, answer me this, all of you. Look at the question. ध्यान से पढ़ो. A lesion of left temporal lobe is most likely to affect which visual field quadrant in the left eye? Let's solve this together. Left temporal lobe, I am giving you a hint, means first of all, temporal lobe lesion will cause pie in sky. Correct? It is left temporal lobe lesion. That means right-sided pie in sky. So if this is my left eye, this is my right eye. How do I make a right-sided pie in sky? Is this correct? So which eye they are asking you? This is the nasal. If two eyes, ये उसका nasal हो जाएगा field. This is the temporal. So it asking for left eye. What is the answer? Left eye में, is it upper temporal or upper nasal? Anu, you have answered this for which one? Great, Indrangni. Very well done. Yes, all of you. So many of you are answering correctly. Wonderful. Yes. Yes, Apno. This is the answer. This is your upper nasal. Prachi, why are we answering it? It is for the left eye. Look at the figure. I have already shown you the figure. Left side में कौन सा pie in sky, on the right sided pie in sky बनाएंगे ना, because it is a left temporal lobe lesion, we will make a right sided pie in sky, isn't it? So right sided pie in sky is what we have just drawn for you. So if it's a right sided pie in sky, what we will say? Upper nasal of the left and upper temporal of the right. है ना? If this question was about right eye, then our answer would have been upper temporal. It is asking about left eye, so our answer is upper nasal. Is it clear to every one of you? It should be. Anybody has any doubt, you can ask. Each and every one of you is equally precious to me. Just let me know if there is any doubt, we can repeat it. No problem at all. समझ आ गया ना? C क्यों है? Very good, Anjali. Sitakshi, Ragini, all of you, wonderful. All of you have now answered correctly. I'm worried, Prachi, good, you got it, beta? The answer has to be upper nasal for the left and upper temporal for the right. Very good. So, at the end of my session, as a part of the tradition, I always discuss some nice thought for the day. So many of my old students know this. So this time I've got another thought for the day before I end this session. And this session was actually we all are teaching, 20 years of experience in teaching. We don't have to really bother about that where you are. DAMS is a very, very wonderful place to be. It's like a family. What is very important, we are trying to give you the feel in these demo classes is that how beautifully we can still talk to each other, interact, and it is no less than a face-to-face class. And you can just do it on your study table, isn't it? So we will, so that is the purpose of arranging. We are all taking so much effort. Dr. Smith is taking so much effort of arranging all these demos so that you all can get a feel of it. Okay, so what is live chat and live classes and how it is equally comfortable, how you can talk to your teacher. Now, one more thing I want you to know is any doubts, and if you want to approach or ask me something, please use your messenger and ask me. Okay, Facebook Messenger is good. And why I'm not giving you different sources? Maybe because I think little in my old ways that if I feel that if you're too busy in your screen all the time just scanning the different social media, I don't know when are you going to pick up your book and study. So I just don't want to give you hundreds of options. Go for the messenger. You have got your DAMS exclusive club where we answer questions and we ask questions. Anything you can ask on my page. I have my Facebook page or on my messenger. Okay. And on a lighter tone, very interesting about Instagram. Very, very recently, I have made an account in the Instagram, and that also I never did it. You all will laugh on this. It was my younger one playing, and she made my account without my knowing it. For days I didn't know I had an account, or I don't have time to peep into that. But anyway, then finally when she had made it, then I thought I have to settle it little. So, but I am discouraging to go to different social media. Just talk to me on the Facebook page or on the messenger. It's absolutely fine. And you all also should not waste too much time here and there. Study hard. Okay. And we are all there. So this course is awesome and it's all for you. So first your thought for the day. So wherever you go, no matter what, I just love this weather. What the weather is, always bring your own sunshine. What does it tell you? That everything is inside you. When you feel sad, you're happy, motivated, it is inside you. Nobody is doing it for you. So please work hard, run your own race. Okay. And as I said, we all know about this course. I think now all of you must have learned so much about this course, about our DAMS Ultimate Life course, and you know how beautifully we interact and how good it will be for you all to be a part of the DAMS family. So I don't want to say much here because I think you all know this so well, right? So the absolutely wonderful place to be. That's what I would like to say. Thank you so much. And that was it. Sort of weather is cold. So your weather should always be joyful. Okay. Whatever dark times, always bring your own light. Don't depend on others. Be self-independent. Okay, don't wait for others to make you happy. Be the happy yourself. This is what it means, right? Okay, thank you so much all of you. Any questions? I'm looking at the chat if I missed something. Yeah, just see Saurabh. So Saurabh, yes, only FB very recently Insta, but I'm not using it yet. It's like an accidental, it has been made for me. So better you, if you want me to answer you, it will be wonderful if you contact on my page or on the messenger. And you will also study more, scan less. Right? Yeah. Thank you so much. You all are so wonderful. Sort of anterior junction syndrome is kuch fibers optic nerve, some fibers of the chiasma, inferior nasal fibers, which is called Wilbrand's knee, which is detouring from the opposite side. So some fibers of optic nerve, that is why central scotoma, and some fibers of the chiasma, that is why superior temporal quadrantopia. This is what is junctional scotoma or trachea. Okay. You can even see in some types of meningiomas. Again, this area is affected, or it could be pituitary adenoma, right? And I told you which type of pituitary adenoma is more prone. If anatomically it is a post-fixed chiasma, it is more prone. Okay, Saurabh? Oh, you wanted to see that image? Okay, I'll just show you the image. Wait a minute. This one? Or this one? ये वाला होगा. ये. Yes, MS Akhila, I will definitely explain it to you. If you understand what is could you understand the pattern of nerve fibers which are entering the optic disc? So actually, temporal fibers, they enter the disc from above and below. And the nasal fibers and the macular one are entering the disc straight. So जब nasal fibers of opposite side जो affect होते हैं, तो उस आंख में क्या होगा? It will be horizontally, atrophy is seen more, pallor is seen horizontal. That is why you call it as bow tie. That means when I do a fundus examination, when I'm looking at the disc, I will see a pale area horizontally. Okay, what I'll do, I am going to, Akhila, I'm going to post a bow tie atrophy picture on the Facebook, and you can look at it. Okay, on my page or on the club, everywhere. So that it becomes even clear to you what I'm trying to say, that white area is only horizontally nasal to temporal. Thank you, Pooja. Stay blessed. Lots of love. ठीक है अश्विन, अभी बोटाई समझ आई? Please respond. I think we have crossed the time, but I would still like to have the response before ending. Harshit, of course, you should be in contact with your teachers continuously when you are studying, and you are always updated here. You will always know what is new happening, what is the new pattern of questions, that everything. So I really feel that it's always a very, very good option for you. And it's a circular course, 2 batches, you are always getting us live, you are having your recorded. So it's very comfortable, okay? And whatever questions you want to ask, you can always contact your teachers, isn't it? So these are all big benefits, isn't it? And even there will be doubt solving sessions in this course. So that will also help you all. Thank you all of you. I am just waiting for the response from Ashwin. Ashwin, bow tie samajh mein aayi? Do you want me to repeat? So if Ashwin has not responded to me whether that bow tie wala clear ho gaya, I am just going to post that fundus picture. I forgot to include here. Rather, it didn't strike me last moment पे कि इसको भी लगा दूं, तो उसको मैं post कर दूंगी on my Facebook. You will get that. Don't worry. It is nothing but, अच्छा मैं यही समझा देती हूँ. I just told you that this is the disc, this is the macula, from the nasal. Oh, 1 minute. Just 1 minute. I got this. Ashwin, I'm waiting for your response and then we end. Hope you are here to answer me. So what I just said was, if this is the pattern of the nerve fiber aggregation on the optic nerve which I explained to you all, correct? Ye wala, dekho. So can you see from the temporal part, generally the fibers are ending above and below. So if temporal fibers of one eye is gone, there you will see an optic disc on the fundus where the neuroretinal rim is this partner. So ye pale milega aapko and this one is pale. This is not bow tie. This is on the temporal, when temporal fibers of same side. But what happens on the opposite side? Opposite eye may, this is the cup, and now this part of this and this part of the neuroretinal rim is pale. So this looks like a bow tie atrophy. Why this part? Because I explained you that the fibers from the macula travel straight, fibers from the nasal part is traveling straight like this. Ashwin, what happened? Now is it clear? Now is it clear? So, understood? Yay! I'm victorious. You understood. Thank you. Acha, Anu, I think, what was her name? Oh, you were asking about posterior junction. Posterior junction is what? When the posterior part of the chiasma is involved, and whenever there is a posterior part of the chiasma which will be involved, what will happen? I'm drawing it again for you here. Macular fibers are mainly affected. It has to be heteronymous, na? So this type of field defect you get. So this is macular but heteronymous field defect, isn't it? Heteronymous hemianopia. Okay? And who had asked this? Harshit, you can just message me and we can talk on Messenger. Just message me. Don't worry so much. Right? Got it? What is posterior junction? One of you had asked me. Anu, yes. Anu, you got it? Okay, so now we end the session here. Yes, thank you so much. God bless you all. Stay blessed and keep smiling and be happy. Okay? Thank you.